teams are having. So with that, I would like to introduce Dr. Tricia Wright. She's a clinical professor of OBGYN and reproductive sciences at UCSF. She's widely recognized for her expertise in substance use disorder in pregnancy, addiction medicine, and women's mental health. Dr. Wright founded the Waikiki Path Center, which is Hawaii's first perinatal clinic for women with substance use. And she's widely published on the topics of perinatal addiction, opioid use disorders in pregnancy, and harm reduction. Her many accolades include being honored as a Distinguished Fellow of the American Society of Addiction Medicine, or ASAM, in 2019. So with that, I will stop sharing my screen and welcome Tricia.
Now I need to find my screen and unmute myself. Okay, where'd it go? It was here. I think it, sorry. I will be with you. Thank you for having me and putting up with my tech challenges. I'm trying to catch an airplane, so it's all good. That's what I get for trying to do too many things at once. It is booting up. Let me try that again. Go back.
There we go, we can see
There
it.
we go, good. Okay, so today I'm going to talk about screening, brief intervention, referral to treatment on labor and delivery specifically. A bunch of us wrote a paper a few years ago about SBIRT during prenatal care or during the perinatal period. And a lot of people have then asked, so what about patients that present to labor and delivery without prenatal care? How do you go about screening them without doing urine toxicology, given, the racial and implications of that. And so that's where this comes from. Disclosures, I do receive consulting income from McKesson, not related to the content of this talk. And I do receive royalties from our book, Opioid Use Disorders in Pregnancy. However, it's not gonna let me retire anytime soon, unfortunately. The objectives is just to recognize the importance of screening all women of childbearing age for substance use, being able to incorporate validating screening tools into clinical care, and identify motivational interviewing techniques so that a positive screen doesn't get ignored, but triggers the appropriate team-based approach. So why bother screening and doing brief intervention? The reasons not to talk about substance use, we don't have time. There's too many other things to do, too many other things to screen for, too much to do clinical care. We don't know how to ask, and this was a big question when I met with a bunch of labor and delivery nurses yesterday. Just that is one of the biggest things they said is just how do we bring this up in a non-judgmental way, and how does it look like, so it's just not checking a box. If people feeling that it's not my job, we're not trained as a therapist or counselor, really having no one to refer to, and I would say for sure, if you're not being able to appropriately refer, that screening shouldn't necessarily be done, because you're bringing up a lot of difficulties with the patient if there's not anything that really can be done to help them. I hear this, and I heard this from my own hospital. We don't have drug problems at our hospital. We don't have that in our clinics. And if we do screen and do this, patients won't change. And then the common truth, actually, but they lie to me, and it's there's very good reasons why patients don't disclose their use, and very valid reasons, and we need to realize this, not take it personally, realize there's a fear of stigma or judgment. There can be a previous bad experience with a healthcare provider, a fear of child protective services, or they don't consider their use problematic. So one thing we can really do is work on minimizing stigma. So substance use disorders are the most stigmatized medical condition. This has been shown in several studies, and pregnant women with substance use disorders are even more stigmatized. And this is really reinforced in the lay press, and even in some professional circles. But terms such as crack baby, which started in the 80s and 90s, really stigmatized a whole group of infants that then grew up into children, and now they're adults and have had to live with this stigma their whole lives. I have a coworker who just finished his MFM fellowship who calls himself a recovered crack baby, and he's a very successful person. So to realize that this stigma follows them throughout their lives is just really tragic. And one thing we need to remember, that babies aren't born addicted. If you look at the DSM-5 criteria, they don't fit any of them. They are physically dependent on opioids or other drugs and are going through withdrawal, but that does not meet the definition of addiction. Really working towards an addictionary, focusing on person-first language, using DSM-5 terminology is very important. And just remembering that this is from the NoFast website, so the fetal alcohol syndrome prevention website. Just realizing that no woman drinks because she wants to hurt her baby, and no woman uses drugs because she wants to hurt her baby. They have a substance use disorder and then become pregnant, and pregnancy is just part of their life course. Some of the we already talked about this. Some of the things we can talk about minimizing stigma is really changing the language of addiction, really being careful not to call people an addict, abuser, user, junkie, druggie, or any of those terms, and really focusing on person-first language, a person with an addiction or a person with an alcohol use disorder or opioid use disorder. Talking about a person in recovery as opposed to a clean and sober. That being said, the most important thing when you're referring to, if you're referring to a specific patient is asking them how they prefer to be addressed, because they have specific languages that they can prefer. But in general, and especially if we're talking amongst ourselves, and to people in the community, we really need to focus on these languages. And especially clean or dirty as far as regarding a drug test. No other chemical test do we refer to that as that. We really talk about negative and positive results. And a study that shows really the importance of language was done in 2010 with doctorate level addiction and mental health providers. They provided case scenarios of patients with legal difficulties from substance use. Half the scenarios used substance abusers and half used persons with a substance use disorder. They were identical scenarios, yet the scenarios with substance abusers were significantly more likely to be judged as deserving punishment than the exact same scenarios as those having a substance use disorder. So that's why language is so important, because these are people that really do care and do know better. Some of just a really bad obstetric outcome that we had in Hawaii, a patient presented for care to a federally qualified health center. She saw one of my partners for a prenatal visit at 27 weeks. She had severe methamphetamine-induced cardiomyopathy with an ejection fraction of 15%, so very poor, very high risk of congestive heart failure, and especially during pregnancy. She was admitted, told that she really needed to go to the hospital. That would, and we would really try and optimize her care. And she just flat out refused. She said, when, I can't go to the hospital. They're always so mean to me when I go. And the same thing why she hadn't gone for prenatal care. So when she had a cardiac arrest at 32 weeks, brought into the emergency room and had an emergency cesarean section in the emergency room, she and baby both ended up on life support for a week before care was withdrawn. And so this just illustrates how much stigma kills and how much our language and how we treat people really matters, not just for them, but for their whole families. When we talk about other reasons why patients don't disclose their use, if you have to think about drug-related criminal justice, and women are a fast-growing population of the U.S. Prison population. More than 60% of women in federal prisons are incarcerated for non-violent drug-related crimes. And part of that is for plea bargaining, which punishes those not willing to inform on others. There can also be conspiracy charges that, if they're living with a drug dealer or something like that, and those result in mandatory minimum sentences. And I can tell you, trying to find a family member housing who's had an arrest record, it's darn near impossible. And we wonder why they have such a hard time, getting jobs, getting public assistance or housing with an arrest record, and why there's such a homeless problem with homelessness. We know that race and ethnicity plays a big part in this inequity. We know drug use occurs at similar rates across groups, but compared to white women, Black women are almost twice as, Latinas are 20% more, and Native Americans are 6 times more likely to be incarcerated for drug use, and especially during pregnancy. And we also know that Black women are no more likely to use illicit drugs during pregnancy, but are more likely to report it to child welfare. We know that 60% of women in prison are mothers of minor children, and the health and social situation of mothers involved with child protective services deteriorates after their child is taken into care. So keeping moms and their children together really improves outcome for both. We know that CPS can be very damaging and can lead to relapse and overdose. We know that women with a child or children in foster care were less likely to complete treatment for their substance use disorders. Women who use drugs who are uniquely vulnerable to criminal justice and child welfare involvement if they admit use or test positive at birth. And so yet another reason why patients don't disclose their use. Criminalization of drug use puts mothers and fetus at great risk, create barriers to treatment and prenatal care, so it causes women to avoid prenatal care. We also know prisons and jails use restraints during labor and delivery. I just recently had a patient on the antepartum unit, handcuffed to the bed. I'm not sure where she was going. And prisons and jails also denied breastfeeding, which is harmful to both mother and baby. So all reasons why patients don't disclose and why we shouldn't screen, but I turn that around and ask, so why should we screen? We know that substance problems are common. You can see here that smoking cigarettes or tobacco is the most common substance used during pregnancy, and about half the women are able to quit and half are not. It's the most common substance continued to be used during pregnancy. We can see that drinking during pregnancy is extremely common, including binge and heavy drinking, which are most associated with fetal alcohol syndrome and fetal alcohol spectrum disorders, which are by far the most harmful substances used during pregnancy. And we can see that 5% of women continue to use illicit drugs, and this has different meanings for different states, and states such as Colorado or California where it's legal. This has a different meaning, obviously, because cannabis is one of the most common, or the most common illicit drug used during pregnancy. And if you compare that to things that we screen for routinely during pregnancy and the prevalence of those, we can see that those are as common for the, the substance use is as common for the things we commonly screen for, including gestational diabetes and preeclampsia, second only to postpartum depression. We know that substance use disorders are expensive. This is old data, but even back then, it costs $500 billion annually to treat substance use disorder. And comparing that to diabetes and cancer, which get a lot more funding from both the government and non-governmental sources, you can see that it eclipses it. And we know that programs designed to prevent substance use can reduce costs. So really focusing on that with SBIRT and other things can really save a lot of money. And we know that substance use disorders are treatable. There's chronic relapsing condition, just as hypertension, asthma, or diabetes. We know that the success rates of treatment for substance use disorders are comparable to treating hypertension, asthma, or diabetes. And we know that medications to treat opioid use disorders decrease death by all causes in people with opioid use disorder by 50%. No other medication, if you think about it, no other medication, with maybe the exception of insulin, really can reduce death by that much. And we know that SBIRT, in addition to helping people with substance use disorders, can really help prevent the development of substance use disorders by intervening when the risk is, moderate and they haven't developed a substance use disorder yet. So what is SBIRT? I think you're all probably familiar with it, but it's a comprehensive public health approach to delivery of early intervention and treatment services for those with the substance use disorders or of those at risk of developing these disorders. And really, SBIRT can be used for any behavioral intervention or the treatment process for any health behavioral change. What is SBIRT? Consist of, screening, really, which is to quickly assess the severity of substance use and identify the appropriate level of treatment. This can be either with a patient administered instrument or provider questions. So a brief intervention is really used to increase insight and awareness of substance use and motivation towards behavioral change. It's brief, should take about 3 minutes, and really based on motivational interviewing techniques. And then referral and treatment, providing those identified as needing more treatment with access to specialty care, and really developing those systems of care. And that's where it goes in the hospital, situation, is to really develop your teams so that patients that do screen positive are able to be taken care of during that hospital stay, and really services can be wrapped around appropriately. So when the SBIRT process should be taking place, we recommend that SBIRT be done at annual exams and new OB visits, and then rescreening with mental health screening during every trimester. So if you're rescreening for depression during every screening, also rescreening for substance use. And upon admission to labor and delivery is a good time also. And for those with identified problems, following up at subsequent visits. This is just a schematic that we developed with our SBIRT article with this CDC, really recommending universal screening for everyone. And this can be done with a brief questionnaire, an interview, or even computer-assisted assessment. There's some studies of doing actually the full SBIRT on the computer system. And something that I'm interested in our OB clinics, because they're so overwhelmed with everything else that we need to do, that this might be, and this in our patient population with high health literacy and high access to internet, I think it might work really well. But the purpose of that universal screening is really to stratify patients into this risk pyramid. And the majority of patients are actually going to be low risk. And so really nothing really needs to be done at that point, just a brief advice. That's wonderful that you don't drink now, because we know no amount of alcohol is safe in pregnancy, things like that. If they screen in this moderate risk, so if they had high use in the past, or risky use, recent stopping, or stopped use late in pregnancy, or for the woman that has continued low level use of alcohol, for example, this can be really, during pregnancy, this can be a great time to do just a brief intervention with some motivational interviewing techniques, and really providing information. If they do then identify as being at high risk, current heavy use during pregnancy, any use of alcohol or other drugs during pregnancy that continues after a brief intervention, probably does pathognomonic for having a substance use disorder, because by definition it's they're using during a risky situation. So and this is only about 4 to 5% of patients, so it's not a whole heck of a lot of patients, but it is more than we would imagine. So after, what can you expect after the screening? Results are available. Only a small portion will need a brief intervention. And the goal of the brief intervention is not to cure the patient of the problem, just to instill some level of awareness and possibly referral to special treatment if necessary. So this is how a SBIRT flow could look on labor and delivery, universal screening, and we'll talk about what that means. And if they screen negative, just continue with the admission. If they screen positive, just be doing a little bit of brief intervention while you're talking to the patient, doing some other things. And then referral and treatment, which activating a team-based approach at that point, and then following up. So how do we screen for this? So just doing a little poll, and hopefully this will work. No, I don't have polling. But, if you can think about this, what your hospital protocols are: universal urine toxicology on all birthing people. Anybody have that? Raise your hands or put a little thumbs up in the chat or something. And what about urine toxicology with certain criteria, if they have no prenatal care or pregnancy complications such as abruption? Universal verbal screening, thumbs up, anything, anybody? Or I'm not sure, or we have no protocol, which is probably the majority of people.
I'll just share a couple of folks put in the chat option 2. So yeah.
Okay. All right, which is very common. But unfortunately, because there's no protocol, or it's left to the discretion of the provider, it can be fraught with racial bias and other things. And I'll talk about that in a minute. So what about the need for universal screening? And it's really asking every woman about use using non-judgmental language. This is one way you can do verbal screening if you don't have an instrument, but I ask all my patients about the things they can do that affect their health, starting with something benign. How much do you exercise? How many cigarettes have you smoked in your lifetime? How much alcohol did you drink before you got pregnant? Have you ever used drugs for reasons other than medical? And specifically not out. Now I'm asking, you don't use drugs, do you? Because of course the answer is no. And really don't ask just to check the box, as one nurse expressed yesterday on a call. So this is just some examples of some screening instruments that can be used that are validated. The NIDA-4, in the last year, have you smoked tobacco or vaped? Had more than 3 drinks of alcohol in one day or more than 7 in a week? Used a prescription for something other than prescribed? Used an illegal or illicit drug? Or used marijuana, in the states that have legalized cannabis? And then if the answer is yes, then the screen is positive. So if you think of a screening test, it's something that should be pretty sensitive, because you're wanting to cast a wide net. And then you go into the assessment at that point, and then you can be more specific there. And I understand most places in Colorado use the audit, which I think is fine for alcohol you know, it's, especially if you're scoring it for pregnant women, any alcohol use in the last week is considered high risk. And the 4Ps has some advantages. You're asking about parents and partner, which can really also screen for domestic violence at the same time. And sometimes they feel more comfortable talking about their parents' use than their current use. So it does have some advantages. It's also a little cumbersome. It's very sensitive, not very specific. And some of the thoughts from labor and delivery nurses, just because I wrote down everything they said yesterday, I was so rich with information, but you know, just in things they expressed, we need training on assessment and care management. We have all the empathy we want, but we don't have tools and systems. Patients will continue to be harmed. There's a checkbox stale admission question about substance use. Curious if there's a better way to assess and address this that doesn't feel so clinical and rushed. We as nurses don't know what physicians can do and how to get referrals going. Nurses don't know what resources are available. So just some thoughts from that. And then just getting into the difference, because I get asked this all the time, what's the difference between screening and, you know, why don't you use urine toxicology for screening? Urine toxicology testing, you know, just some of the differences. Screening is universal, verbal, non-judgmental. It's really an opportunity to destigmatize use, make it part of the routine medical care. It's an opportunity to offer services. It's really supported by this as the gold standard by both ACOG and ASAM and AAP. You know, to be fair, it can cause harm if not done in a trauma-informed way, which is kind of beyond the scope of this to talk about trauma-informed care, but just realize that it needs to be done in a sensitive way. The difference with testing is it's testing various biological options and frequencies, so either urine, meconium, hair, umbilical cord, etc. The problem with that, false positives are not infrequent and can have devastating consequences. And it's really a qualitative data. It's, you know, trauma and triggers related to testing to do use of policing families. And it's only diagnosis recent use. It's not diagnostic for a substance use disorder or a diagnostic of the ability to parent. So, a pediatrician, a friend of mine likes to say, you know, it's not a proxy for parenting ability when we do it for patients that have prenatal care, and that's what we use it for a lot. Just some things that can cause false positives on urine drug testing if confirmatory testing is not done. And the confirmatory testing can take 3 to 4 days to results. So the initial screening can be quick because it can be even a point of care urine you know, cup, but there's multiple things that can cause a false positive on that, especially with amphetamines, you know, and things like cough syrup and things we give like labetalol in pregnancy. So if you think that that can, you know, raise all sorts of red flags, can prevent women from breastfeeding and all sorts of things until we're waiting for confirmatory of that. So just looking at the sensitivity and specificity of the various screens, I don't have the audit on here, but looking at the 4Ps plus, it's very sensitive, as I mentioned, 91%, not very specific, obviously, because you're asking about other people's use other than their own. You know, very high negative predictive value. I prefer the NIDA-Quick screen. It's not quite as sensitive, but it's a lot more specific and fairly high positive and negative predictive value. The SBIRT is one that's very sensitive, not very specific. And it's another one, I didn't put it on here, but can be used. If you think about who we test, you know, if you're testing people with no prenatal care and they don't have access to prenatal care because of their race or ethnicity, then you're differentially, you know, causing them harm. We know that substance use is similar by race and ethnicity in the U.S. among women. Women is in quotation because they don't have gender inclusive data. But numerous studies have shown that Black pregnant people and their infants are more likely to have drug testing at birth. And after a positive test, Black birthing parents were 10 times more likely to be reported to CPS. So we, you know, really see racial disparities here, and we really see racism in medicine here. So just another thing to think about. And some of the long-lasting ramifications of drug testing, you know, these are thoughts going through patients' head. Are they going to take my baby? If you can think of, you know, one thing more traumatic to a person is, you know, having to give up their baby without their consent. Is the hospital going to take my baby? And you can think of, you know, just the fear based on this. So one thing we're doing at San Francisco General and trying to coordinate this with the UCSF hospitals also is revising our urine toxicology testing guidelines. So it's a clear protocol. You know, the purpose is really to aid in the identification of pregnant or birthing people who need support related to substance use, identifying birthing parents and infants exposed to substances who may need specific clinical treatments, you know, example treatment of withdrawal, minimizing bias and discrimination in caring for patients and families, and really not using it to assess parenting ability or safety of the infant. Some of the noteworthy points: it's a multidisciplinary group, it's leading the review process, and then even when it's finalized, it will be an interim policy. We've pretty much finalized it, but we're going to allow, you know, keep it interim to allow community review, especially the communities most harmed by the policies in the past. Our goal is to be narrow with the indications, decreasing the use of urine testing, and again, only with consent. Verbal disclosures almost always eliminates the needs for biologic testing. So if a patient discloses their use, don't necessarily need to do it to catch the person or whatever. Though sometimes, you know, it can be helpful, especially with the our drug supply so contaminated with fentanyl. Just knowing what patients are actually taking can be helpful, but again, with the patient's consent. A birth parent with capacity must consent to urine testing, and infant testing really requires disclosure to the birth parent, so it can't be done without that. Birth parent toxicology testing is always preferable to newborn testing. It comes back faster, and it also doesn't look quite as bad to CPS. But you know, there's a lot of reasons not to do toxicology on the parents in addition. So really making it a collaborative, thoughtful approach and not something that's just done knee-jerk or capriciously depending on the provider. Newborn testing should only be performed if there's clinical indication for newborn management, and birth parent declines testing. We are working on, and I'll talk about this at the end, a universal timeout for, just like we do with any other high-risk procedure or any procedure really, is having a universal timeout prior to calling CPS. We're working on doing that with urine toxicology. So it's a group decision allowing an opportunity for reflection on potential bias, discrimination, and harm reduction strategies. And our goal is really to be consistent across both hospital systems. Some of the guidelines and processes, you know, birthing parent considerations: if they have acute mental status changes, psychosis, manic symptoms, or somnolence not otherwise explained, that can be a reason to do a urine toxicology. I mean, it would be wonderful if we could do it just like any other medical test and wouldn't be available in the medical record to child welfare, because, you know, it's a medical test. But unfortunately, that's not the case. You know, if they have behavioral consistent with intoxication or withdrawal, such as slurred or pressured speech, incoordination, or extreme agitation, because it's being used for medical reasons to diagnose a condition. Because if it's not used, not due to substances, there's something else, you know, either medically or psychiatrically wrong with the person. And also, if desired by the birthing parent, and this is, I had this all the time, really to demonstrate recovery and or safety of breastfeeding. And there's a lot of discussions on breastfeeding and infant care, and really, you know, if they're continuing to use illicit substances, especially stimulants, is that safe? And really, and you know, providing anticipatory guidance to parents. Newborn considerations is to guide treatment of the newborn care, newborn behavior consistent with intoxication or withdrawal. Other causes of newborn clinical presentation should be explored, not just saying, oh, it must be drugs. You know, really looking at withdrawal from other substances that are legal, such as nicotine, prescribed substances such as antidepressants, making sure they're not having hypoglycemia, etc. You know, I was mentioning using late to care or no prenatal care, really offering testing, what causes more harm. We looked at Black birthing people in San Francisco, and nationwide, Black birthing people had 3 times more likely to not have prenatal care. You have to look at all the structural racism surrounding that, you know, access to care in neighborhoods that aren't safe, you know, inability to get care for other children so that they can obtain prenatal care and things like that. So traditionally, instead of, oh, patients not, you know, caring about the pregnancy or trying to avoid prenatal care, oh, they must be using drugs, really thinking of the other systemic causes why they would avoid care. We know in San Francisco, a positive urine toxicology was really associated with no prenatal care. So, you know, really looking at that and as a reason to get urine toxicology, because, you know, like, it is not diagnosis of substance use disorder, and it shouldn't be used as a proxy of their ability to parent. So, you know, you've done the screening. I use this as, you know, because the only screening tool I was taught in medical school was that CAGE questionnaire, which is not validated in women, and certainly not validated in pregnant women. But but you've caught her in a cage with your screening questions. Now, what do you do? How do you, you know, do a brief intervention? I know you've had other lectures on this, and so I'll kind of go through this a little more quickly, but just really talking about motivational interviewing. The techniques were first described by Miller in 1990. It's shown efficacy in emergency rooms, decreasing alcohol use in pregnant populations, and increasing tobacco abstinence in pregnant populations. And so it has been shown to be successful with both alcohol and tobacco, which are the 2 most common substances used during pregnancy. And some small studies have shown success in illicit drug use in pregnancy. If you think of the you know, Prochaska and DiClemente's stages of change model of behavior change, what you're trying to do with motivational interviewing, you're not trying to get someone from pre-contemplation to action. It's not going to happen in 1 3-minute brief intervention, but what you're trying to do is really nudge them along so that they can think about their use and really help them prepare to take action and, you know, continue to maintain their goals. And what motivational interviewing is really working is the heart of the problem is working with ambivalence. So we know that ambivalence is normal. People want to change and they don't want to change. If you think of some behavioral change in yourself, you can think of the good things about it and the bad things about it. And it's always ambivalent. You can know it's harmful for you, but there's some things that you really enjoy, and it's the same with people that use drugs. And so working with this is really working with the heart of the problem. The decisional balance, I like this. I did this for a couple of decisions I was trying to make, and really exploring the pros and cons of the current behavior. What's good about it and what's not so good about it. What's good about stopping, what's not so good about stopping, and really getting, kind of the overall balance. The principles, really expressing empathy, asking open-ended questions, developing rapport. In Hawaii, we talk about talking story. So really talking, getting to know the patient as a person, and really exploring what's important to them. Really supporting self-efficacy or belief that change is possible. Rolling with resistance. So if you're building a whole, lot of, resistance to behavioral change, trying a different tact, or just not being so invested in the outcome. And what you're really trying to do is just develop the discrepancy between the current behavior and future goals. And we know this is a lot easier in pregnancy, because 99% of pregnant people really want a healthy pregnancy and a healthy infant. The 3 tasks: just feedback, listen and understand, and exploring options. The flow does not include warnings. How not to motivate people. I talk about when I was 13, I went to a pediatrician, and I was a little chubby as a kid, but not too bad. I went in there. He plots my height and weight on a chart and says, "You're 8 pounds overweight. You need to stop eating carbs." So what was the first thing I did? I went to, I think there was Village Inn Pancake House, and had waffles afterwards. And I never went to that pediatrician again. I couldn't stand him. He was a jerk. But that just shows you that's really not how to motivate people to change. You shouldn't give unwanted advice. You shouldn't be, warming, shaming, labeling, playing the expert. Your job in feedback is only to deliver it. Asking permission first and foremost. Exploring the risk to the mom and the baby from her behavior, or the parent and their infant. What have you heard about the risks of drinking during pregnancy? We know that drinking during pregnancy can cause birth defects, and no amount is considered safe. What do you make of that information? And let the parent decide where to go from it. Not, you shouldn't drink during pregnancy, it'll harm your baby, because that's going to meet with so much resistance. Well, I drank during my other pregnancies and they're fine. So really finding a hook, asking the client about their concerns, providing non-judgmental feedback and information, watching for signs of discomfort with the status quo, or interest or ability to change. We call that change talk. And if you've done an MI session, we talk about snapping with the change talk. Always asking the question, what role, if any, do you think alcohol, smoking, drug use, whichever the problem you're working on, played in your problems? Letting the patient decide, and really just asking the question is helpful. So even if you don't go any further, just asking that question. Rolling with resistance. I'm not going to push you to change anything you don't want to change. I'm not here to convince you that you have a problem with alcohol. I'd just like to give you some information I'd really like to hear your thoughts about. And what you do with it is up to you. The readiness ruler, I think you've probably heard about this, but on a scale of 1 to 10, how important is it for you to quit smoking? If they say it's a 7, well, that's a pretty high number. And what makes it a 7 and not a 3? And how confident are you that you can change? And how ready are you? And for each, just ask why didn't you give it a lower number, and what would it take to raise that number? A third task is really providing options for change. What now? What do you think you will do? What changes are you thinking about making? What do you see as your options? Where do we go from here? What happens next? Offering a menu of options. With smoking, they can manage their smoking. They can cut down, they can eliminate it. They can wash their hands and change clothes after smoking. And there's a lot that can be done with harm reduction. And just the fact of getting prenatal care is really harm reduction. And we need to really embrace that in patients. Even if they're not willing to change their behavior, we can mitigate their harm. They can do utterly nothing, and they can seek help. And I did this with a patient who was doing some MI about smoking, and I provided her this menu, and I said, what are your plans for this? And she said, oh, I have an appointment with a hypnotherapist, which had not been on my menu of options. And I'm like, that's wonderful. And she did. She quit smoking with hypnosis. So, you know, patients will come up with ways that will help them, and they know themselves. You know, developing reflective listening styles. You know, the simplest is just repeating everything they said, or rephrasing, or paraphrasing. But reflective of feeling is the deepest depth, you know, of reflective. It begins with a way of thinking, and it has to include the interest in what the person has to say and a desire to truly understand how the person sees things. It's essentially hypothesis testing. So you're putting out there, you know, so I'm trying to think of an example right now, but with smoking. So it's important that you stop smoking because you really want to be there for your grandkids. When they've said, well, you know, my grandkids, I want to see my grandkids grow up. And even if you're wrong, they can correct you, and that reinforces, once they've said that, it reinforces the importance of that. What you think a person means may not be what they mean, but that's okay. You know, it's okay to say the wrong thing because they'll correct you. A simple flow of motivational interviewing, asking 3 open-ended questions. What do you like about it? How does X get you into trouble? And what is your goal related to it? Followed by a summary. So you like this smoking calms you down, but you don't like that it costs so much and you know it's bad for you. You'd like to cut down your smoking and eventually be able to quit. So just kind of bringing it all into a package. And really supporting self-efficacy in the patient and in yourself as a provider. Brief intervention can affect change, especially with risky use. It's not quite a substance use disorder. It can motivate patients to get into treatment, so really knowing the resources. So up until this point, we've done a screening, we've done a brief intervention, and now referral to treatment. For referral to treatment is patients needing more detox or needs more intensive treatment setting in the hospital. Perhaps it's calling your addiction medicine consults, or, you know, if they've developed, you know, you think their problems is too severe for brief intervention, you want further assessment, or patient wants more of the assistance. Referral to treatment is an integral component of SBIRT. And so really, if you don't have this capability, you know, again, you really shouldn't be doing screening if you're not able to do the referrals. And some things you can do to really make this possible is developing the members of your team. And that can include anesthesia, pediatrics, mental health, social work, addiction medicine, and shout out to the community health nurses because they can really do so much to improve, especially when the patient goes home. You can do some of the ideas, and we're working on this through our system, is, you know, really improving our communication through our electronic medical records, developing problem lists that include, you know, substance use disorders, checklist job phrases, just like every other high-risk pregnancy condition. So our high-risk pregnancy, you know, has a checklist that everything that needs to be completed. You can do this with substance use disorders. Make sure they've had infectious disease screening, make sure they get re-screened at 28 weeks for syphilis, things like that. And make sure that they have met with a pediatrician so that they understand neonatal withdrawal syndrome, things like that. And then really depending on your system, if you're needing to talk with people outside the system, especially getting your 42 CFR to compliant consents to talk with the addiction medicine providers or the substance use disorder counselors. And our pediatricians have really shared with us that they'd be much more comfortable not doing tox screens on the baby, not referring to CPS if they had results of the screening on the chart and an updated problem list. So really including everybody in the team. And obviously this is for a patient that's had prenatal care, but even in patients that have not or hadn't disclosed until that point or gets referred in from someplace else. If you can do the screening when they first come in and have assembling your team. it really does take a village to take care of these patients. Just going to end on the whole idea of CPS timeouts. You know, a timeout is a pause before a high-risk procedure or intervention. We have to do this before we do any procedure in the office or in the operating room. And we know that this is a very high-risk procedure or an intervention. Known harms of separation of mother and baby and the racial biases that exist with drug testing and the inability to obtain prenatal care. We decided that unless it's an emergency, child welfare referrals can only be called after a disciplinary meeting. All right, I'll end on that and we'll open it up for questions.
Thank you so much. We don't have any questions in the chat. I of course, no one is surprised, have my own set of questions, but I'm gonna pause and encourage you to either come off mute and ask your questions or pop them into the chat.
Hi, Dr. Wright. My name is Adam Asalowitz. I'm a SBIRT practice facilitator helping support this project. Thanks for your presentation. It was awesome. A lot of great information. Can you speak a little bit more to like the actual workflow of the when, you know, around of the such acuity around somebody that's maybe not had any prenatal care, they're in labor, you know, of maybe in your experience when it's the when of the best practices of the SBIRT process. So when is the best time to screen? If somebody's in, you know, they're having contractions every X amount of time, you know, is leaving brief intervention and actually talking about the screen after delivery, you know, so just like when in the midst of actually being in labor and delivering a baby, of how sort of the best practices of SBIRT sort of in your view work out.
Yeah, I think, you know, obviously if a patient's, you know, about to deliver comes in, you know, abrupting and needing to do a C-section, that's not the time to really be doing screening. It's the time to really be talking to the patient or trying to treat the acute situation and providing information and things like that. In that case, if we need the information for you know, medical interventions or things like that, asking the questions in a medical way can be helpful. I think if they've had no prenatal care, it can be, nothing needs to be done right away. I think that, you know, that's the whole point of the timeout and everything else. We have some time to take care of the acute medical needs. And even when I'm doing an addiction medicine consult and the patient is actively withdrawing, the first, you know, I'll ask a few basic questions. You know, when did you last use substance, you know, what substances did you use? When did you last use? Get you out of withdrawal before I do anything further as far as the assessment, because they're not going to be able to participate until they're comfortable. And the same with a pregnant woman who's actively laboring. She's not going to be able to participate really in an assessment until that active process is done. So I would say probably, you know, an ongoing, and I think that's why training labor and delivery nurses and training postpartum nurses can be really important, just in kind of some of the basic, you know, questions and way to talk to patients, and also physicians, so that the next day, though, physicians are like herding cats as far as doing SBIRT. One is an analogy I loved when I heard that. I'm like, yes. So having and social work, you know, that's generally the oh, she had no prenatal care, call social work. She has, you know, then the person has like an hour to diagnose the whole patient's background. So if we can, you know, if they've had no prenatal care, activating a team approach, calling the community health nurse, things like that at that point. can be helpful.
Thank you.
Hi, thank you so much, Dr. Wright. I really appreciate all the information you shared today. My name is Ryan, and I'm a public health nurse. And my question really revolves around, I don't know if you can hear me, but
I can hear you. Yeah,
okay,
thank you.
perfect. My question, and I just recently got a new position, so I'm trying to learn a lot right now about working with clients with people with substance use disorders. And what I've encountered is here in Colorado, it seems like if there's a toxicology screen, and I know every hospital seems to have a different protocol, or there's no universal screening or protocol for testing. And so I was curious if I was paying attention to the sensitivity and specificity, because my questions often revolve around like how valuable is this test? Because if someone tests positive, it's an automatic call to CPS, it seems like, and then CPS is involved, and then that's when they reach out to us, which is great. But oftentimes, or sometimes, it seems like the mom is denying use, and yet there's this positive screen. And then sometimes they do like testing on the baby. So I didn't know if you had any feedback in terms of how accurate those baby or like newborn toxicology tests are, because I even have questions about that when mom continues to say she doesn't use and deny use, yet there are these positive tests, and it's hard to evaluate how to support that process in that case. I didn't know if you had any feedback on that. I don't know if my question makes sense, but
yeah, no, I think that's it's a great question as far as, and thank you, and for asking it, because it depends on the substance, it depends on when they last used, and it depends on the substrate. So baby urine is generally only reflective of the day or so prior to delivery. Meconium is supposed to be, the last trimester of use, but it really depends on the substance, because some substances are much more, lipophilic, so they go into fat more. Some much more hydrophilic, and they're in the fluid, and then there's cannabis and THC that sticks around forever, and it's not necessarily even the biologic THC, so it doesn't even have any biologic effects, but it's been there for months, and then there's the false positives, and it depends on if they've gotten confirmatory, and also the levels of what it takes to be positive. So some of the confirmatory to interpret urine toxicology, and it's at least a 3-day course to get medical record, to be able to assess this on a forensic basis. So, and the fact that CPS can make these decisions with not even confirmatory tests is just fraught with all sorts of difficulties. So.
Well, thanks for validating that it's challenging and giving me some background on the complexities. I really appreciate that.
Yeah, I'm sorry it was such a long-winded answer, but it all depends.
So I'm noticing the time, and Dr. Wright, I know that we promised we would let you go at 2 and that you're trying to catch a flight. I don't know if you have a few more minutes in case folks have additional questions, but we can also follow up with you via email if there are any outstanding questions after you need to log off.
Yeah, that's fine. You can send me email.
Perfect.
All right.
Good. Well, thank you so much for joining us today. And as a reminder, if you are not participating in the Learning Collaborative, we will respectfully ask you to jump off the call as we jump into our